Hello, everyone, and welcome to the Dr. R Show. We'll be coming to your living rooms weekly to discuss various health topics with the help of medical experts in their respective fields. Meet my two very special assistants, Megan and Christina.
And I am so excited because today is leg day.
And then inhale as you lower back down.
They will be with me every week to give us tips on healthy eating and proper exercise.
Stretch and keep yourself hydrated.
So welcome to my show as we both learn together. Hi, everyone, and welcome to the Dr. R Show. On today's show, we'll be talking about male sexual dysfunction, an often sensitive subject, but very relevant to both men and women. Sexual dysfunction is a complicated topic. It involves not only a man's peripheral brain, but the entire central nervous system. The male sexual response begins with the brain, which sends excitatory signals traveling down the spinal cord, through the pudendal nerves, and into the penis, where chemical messengers cause the penis to become erect through vasodilatation. A problem anywhere along this pathway can create issues with sexual function. To help us understand this topic, we have with us today Dr. Jason Greenfield, who is an expert in this field. Dr. Greenfield is a urologist at the Center for Human Sexuality at Urology Associates of North Texas. Prior to that, he was an assistant professor of urology at Columbia University in New York City and the director of the New York Center for Human Sexuality. Dr. Greenfield, what are the various phases of the human sexual response?
Well, we can go back to what Masters and Johnson first said many years ago. They put it in a graph form where there was a period of excitation, then plateau, which then led to orgasm, and then finally resolution. Obviously, we look at it more complicated and more scientifically, as you mentioned at the beginning of the segment.
And what is sexual dysfunction?
Well, sexual dysfunction actually encompasses a variety of disorders. They can involve anything in that sexual response cycle that we discussed. So problems with excitation or orgasm, and then perhaps a difficulty in actually wanting to engage in sexual intercourse in the first place.
And so what are the different types of sexual dysfunction problems?
So in a man specifically, we usually group them into a few different categories. One is the excitation with erection, and then there's also disorders of ejaculation and orgasm. And then there is also, in some men, a disorder of desire as well.
And what are the causes of these various problems?
Well, as you mentioned again earlier, there can be a disorder that happens at any point in that pathway. Starts in the central nervous system, and there can be causes that relate to that. And then that can also go down into the peripheral nerves and then finally into the main components of the sexual organ itself. So you're talking about blood vessels, nerves again, muscle tissue, and then also there can be hormonal factors. And anything that can affect any part of that pathway can be involved.
So how do you evaluate a patient who comes to you with complaints of sexual problems?
Well, really the first part is to identify exactly what that patient is complaining of. Certainly different sexual disorders can happen together in pairs or even more than two disorders. And then some patients will have a hard time communicating exactly what the problem is. So is it a problem with erection? Is it a problem with ejaculation? Do they also not have a desire? So that's the first step. And then really getting a sense of exactly what's going on with that problem. And then once we know that, then we can go on and do a physical exam and order any necessary tests, which are often related to doing blood tests, and then sometimes there may be an x-ray or some other test involved there as well.
So what do you look for on physical exam?
Well, generally we're looking for normal genitalia is the first part. So we'll examine the man's penis and his testicles, make sure they're all appropriate size and there's no abnormalities there. And then there may be some other things that we look at. So for example, if we feel there may be a circulatory problem, then doing a brief exam of his peripheral pulses could be warranted. If we're worried about a neurological disorder, then doing a brief neurological exam could also be involved. And then also generally looking for normal male development. Does he have normal body hair distribution and so forth?
Now, you mentioned three types of sexual dysfunction: erectile dysfunction, desire issues, and ejaculatory issues. Which of those three is the most common?
So in a man, actually the most common sexual dysfunction is premature ejaculation. Erectile dysfunction gets a lot of attention, partially because we actually do have some very good treatments for it, but actually disorders of erection are number two. And then past that, you get into things like anxiety about performance and disorders of desire. That's in contrast to women. Now, in women, the more common disorders would be disorders of desire as well as arousal and orgasm.
And how common are ejaculatory disorders?
So actually, it's estimated that about 40% of men have a premature ejaculation. Almost seems like the norm.
That's almost half of men.
Yeah, yeah.
And does that increase with age?
Actually, premature ejaculation does increase with age, but really not by a whole lot. And the reason why is the majority of men with premature ejaculation, as we think of it, have it as a primary disorder. That's their own body chemistry. Now, other disorders can lead to premature ejaculation, prostate problems. Erectile dysfunction itself can actually cause premature ejaculation, but the curve doesn't take quite as much of a sharp incline as it does with erectile dysfunction.
So is premature ejaculation a normal physiological response?
It's a good question. And it's hard to really say. I think it's important to think about it in an evolutionary sense. If there's any other disorder in the genital region, what the body's natural response may be is to have the man ejaculate in order to deliver sperm for the purposes of procreation before he loses the erection or is unable to reach orgasm. So in a way, it may mimic a sort of a response that helps propagate the species, so to speak.
So it's efficiency at its finest.
Maybe.
Now, what about erectile dysfunction? How common is that?
So really, I think the best way to estimate it is take a decade of age and then just transfer that to a percentage. So for example, about 40% of men in their 40s will have erectile dysfunction, 50% of men in their 50s, and so on.
That's a huge market for the pharmaceutical companies.
And that was recognized, certainly, with the advent of oral medication.
Now, what about desire issues? How common is that?
So, again, less common in men, certainly, than women, but it is a fairly common disorder. Now, in men, we usually think that it could be caused by more hormonal factors, and certainly testosterone is the major drive in men for libido. There can, of course, be other factors. Another very common reason to have a decrease in desire is medication. Many medications that we give for various conditions can affect a man's libido as well.
Which medications commonly do that?
Mostly psychiatric medications, so the common drugs that we use for things like anxiety and depression very commonly will cause a decrease in libido.
Now, how do you treat premature ejaculation?
Premature ejaculation, amongst the various ejaculatory problems, is actually the one we probably have the most research and treatments to offer. Many years ago, the only thing we could offer was psychotherapy. But now that we recognize that it is truly a biologic issue in many men, we do have some treatments. Now, these were found in a way by accident, as we find many treatments. What we found was that when we used certain medications, again, like medications we use to treat anxiety and depression, that men were having a harder time reaching climax. And in turn, what we did is said, well, if we give this to a man who's actually having a prematurity issue, will that help delay orgasm? And in fact, they do. So the serotonin reuptake inhibitors have been used very commonly. There are also anesthetizing creams and that type of thing, so a topical therapy that can be used, and those can be effective in some patients as well.
So you use antidepressants, such as SSRIs, for premature ejaculation, yet on the other hand, they can reduce desire.
Yeah, and so when a patient is going to try using an SSRI, for example, for premature ejaculation, they have to understand that there may be a reduction in desire. There may actually be a reduction in the quality of their erection as well.
We need to take a quick break. Later in the show, we'll talk more with Dr. Greenfield about the treatment of sexual dysfunction and when surgery may be needed. Please stay tuned.
Hey guys, and welcome back to this week's edition of Inside Fitness. I'm Christina and this is Megan, and I am so excited because today is leg day. So the legs are made up of two main muscles. You got your quadriceps in the front and your hamstrings in the back. Those are the ones that we're going to be working out today.
Now, although you use your legs every day during regular activities, you still need to be sure to train them in the gym. You don't want to be that person that has the built, in-shape upper body and then those scrawny, tiny little legs. So Christina's going to demonstrate the leg extension for us. So first, she has adjusted her seat so that her knees are right at the end of the seat.
And there's actually a notch here that you can use as an indicator on most machines to where your knees actually need to be.
Now that pad down at her feet is actually adjusted so it's sitting right at the top of her shoelaces. So then you're going to grip the handles off to your sides and then exhale as you press the weight up to a full extension. Hold for a couple seconds, then inhale on the way down. Now she's trying to get a full extension here without locking the knees. You never want to lock a joint out. That's really going to cause some extra stress and could cause an injury.
And something to note, like we've said before, whenever you're exhaling, that's when you're trying to exert that extra energy. So go ahead and press your legs up really quickly, but make sure when you bring them back down that it's nice and slow and controlled so you can feel that muscle contraction all the way down. Do this for about 3 sets of 10, and then we can move on to our next exercise,
which is going to be the back of the leg or the hamstrings. Now we're going to head on over to the leg curl, which is going to work the back of the leg or the hamstrings, which is the opposite of the leg extension. So first you're going to adjust the seat so that the back of your ankles are seated on the leg rest. Then you're going to drop this bar down to lock your legs in place to really help isolate the back of that leg. So now go ahead and exhale as you press the weight down till your knees are at about a 90-degree angle, and then inhale back to a full extension.
All right. So just like with the leg extension, whenever you're exerting that pressure, that's when you're going to be doing the exhaling. But here, it's just slightly opposite. So as we push down, you just exhale out, and then when you inhale, you just want to make sure that you're really keeping those legs really nice and engaged, making sure that you are actually working that muscle and not just flopping about.
Now remember that your daily activities does not count as your leg workout. You still need to get to the gym and work those muscles out.
And even if you can't get to the gym, there are a couple exercises that you can do at home, like lunges or squats, but really just make sure that anything that you do, it's nice, it's slow, and it's controlled, and you're not compromising form. All right, that's it for this week's edition of Inside Fitness. I'm Christina, and this is Megan. Try to incorporate some of these exercises into your workout routine this week, always remembering never to compromise form, stretch, and keep yourself hydrated. We'll see you next week.
Hey guys, I'm Megan and this is Christina, and today we're going to talk about a high fiber grain, which is quinoa, or as I used to call it, quinoa.
Or quinoa, or there's 1,000 different things people say.
Quinoa is very trendy right now, but you may not know what in the world to do with it, and you can actually use it as a substitute to your traditional side of rice. Today we're going to be putting together a breakfast quinoa. So we prepared our quinoa in advance, so you just boil it for about 15 minutes, and then you make sure that you drain it and dry it. So we're going to add the quinoa into the pot.
Okay. And we have it on kind of a low heat. This is actually going to be a type of dish that you can use in replacement of oatmeal or cream of wheat or things like that.
And this is about a half a cup of quinoa. And then we're going to add in about a cup of coconut milk gradually, just to make sure it doesn't get too liquidy. Okay, we have about a teaspoon of almond extract, 2 teaspoons of brown sugar.
There we go. Teamwork.
And then since this is like an oatmeal, we're gonna eventually add in some berries and some toasted coconut. The high fiber content in quinoa can help regulate the body's uses of sugar, keeping hunger and your blood sugar at optimum levels.
And you know, one thing that you did mention is that you can use it as a replacement for rice. So something that you can do whenever you're using it as a replacement for rice and you're needing it to be a little bit salty, you can boil it instead of water in chicken broth. Or you could use a bouillon cube depending on what you're fixing it with.
Yeah, and quinoa is actually high in iron and magnesium too. So try adding some quinoa into your diet just to increase your nutrients, your protein, and your fiber without the gluten.
That looks great. So now we have our toasted coconut. We can just stick that right on the top. There we go. And you can top it off with a couple of berries. Hopefully this gives you some new options for breakfast instead of just using your traditional oatmeal or cream of wheat.
Welcome back to the Dr. R Show. Dr. Greenfield is back with us talking about male sexual dysfunction. Welcome back, Dr. Greenfield. Now let's talk about treatment. How do you treat erectile dysfunction?
Well, Ideally, if there was some reversible factor that could be addressed, such as a medication that the patient is on, you'd probably start there. But generally, the first line of therapy for men suffering from this condition would be oral medication. These are your phosphodiesterase type 5 inhibitors. And as a first line, they'll try that a few times, and if not, then we can move on to other treatments if necessary.
And how do those medications work?
Essentially what they do is they cause a further relaxation of the smooth muscle of the penis, and what this does is create the erection and further propagate the erection. So you're getting a greater amount of blood flow into the penis and then less blood flow out, and a firmer erection that's easier to maintain.
But why does it last so long?
Well, the different medications last different amounts of time. So when you have your different brands, some are going to last longer than others, and they also can take longer to work. And based on the exact chemical structure of that particular drug, the body will metabolize it at a different rate.
And so they cause vasodilatation of the arteries that go to the penis.
That's correct.
Now, what about side effects from those medications?
There can be many. I generally tell patients that these are side effects that are not permanent and not dangerous. The most common would be a headache, flushing of the face, stuffy nose, sort of like a sinus headache is what a lot of patients will describe it as. Other less common ones would be an upset stomach, stomach reflux, pain of the muscles in the lower back, and also blurry vision or even a blue tint to your vision are some other common side effects.
And how common are the side effects?
Well, headache is fairly common. When we're talking, ranges of 10 to 30%, depending on the study you're looking at. But in terms of other ones, much less common, and it also depends on which one you're using. Some of them are more likely to cause that backache than others.
And if someone has a side effect, such as headache, what do you recommend to them?
Well, I usually recommend they try it again. Interestingly, men who get that side effect at first will not get it with subsequent uses of the medication, or will even be less intense. If they still have it, then I usually recommend they try at least one other brand, because they may get it with one, but not so much the other. If they're still having it, then it may be something where we need to consider other options.
Now, there have been reports of blindness with one particular drug. Any experience with that?
Well, so I've never had a patient go blind. I've never had a patient, again, have any permanent visual loss or disturbance from the medication. Unfortunately, these studies, when they first got released, really got picked up and caused a lot of concern. It appears now, from what we do know, that there's really no increased incidence of blindness or neon, as this particular condition is called, with these drugs. They've been used by millions of men all over the world, often without a prescription, and we've not seen high rates of blindness really beyond that of the general population.
So the reports of blindness are exaggerated?
I believe so.
Yep. So when the medications fail, what's your next step?
Well, I think it's important, if the patient has not already been informed, to really go over all the other options available to him. So we have various options. There are other ways of delivering medication to the penis to achieve an erection. Generally, that is given either directly with an injection or with a medicated suppository or gel inserted into the urethra. There are also non-pharmaceutical options, such as vacuum devices and penile prostheses.
Now, how does a vacuum device work?
So I have one here. You actually don't need a prescription for this, so this is a prescription device.
Is that a standard size vacuum device?
It
They come in different sizes?
It is. They do come in different
size fits
sizes.
all?
They do come in different sizes, but this is a pretty standard device. Essentially, the man inserts his penis into one end of the vacuum device, and some are battery operated, some are hand operated, but essentially it's going to pull blood into the penis, more venous than arterial blood, but it pulls blood into the penis and creates an erection, and then he uses a restriction band, which I have here, to keep the blood inside.
So what seals this end of the device?
The man will probably have to trim the pubic hair if he doesn't already, and this does form a tight closure when held firmly against the pubic hair.
So you hold it firm, you turn it on, and how long does it take to inflate?
Usually just a minute or two.
And then you take this off and you put this on?
You actually got to have this band on first before you take it off, or it'll leave.
I see. Okay.
This band actually sometimes can create a problem. It can be a little uncomfortable. Unless you have it really all the way at the base, you are going to have a soft area of the erection closer to the body. Also, it can interfere with ejaculation or cause pain with ejaculation, so it's not a perfect treatment.
So first you put this on, and then you slide that device.
Actually, there's a device that helps you slide the band right here at the end of the device, and you need to have that on after the vacuum has done its work. But before you release the vacuum completely, you need to slide that on the base to trap the blood inside.
And how long does this maintain an erection for?
It's recommended that you don't leave that on the penis for more than 20 minutes.
So the penis gets no blood flow at all during this?
Limited arterial blood to the penis, which is why the 20-minute rule is in effect.
So if your penis turns blue, you've had it on too long.
I'd say
Better take
that's
it off.
probably true.
Okay. So that's one option. How do injections work?
Injections essentially mimic what the nerves tell the penis to do. So they sort of mimic the signal. They force the vessels open. Whereas pills sort of just keep the vessels open, injection actually induces the vessels to open. So in a man who's had, for example, a peripheral nerve injury, prostatectomy, spinal cord injury, injections will actually be much more effective than a pill would be.
Now, say you have atherosclerosis and you have hardening of the arteries. Does an injection still work?
It still can. It can still compensate for that. However, if there has been severe vessel damage, an injection may not work.
And how large is the needle that you...
We generally use insulin needles and syringes, so these are very small needles. They're very thin, very short. They're amongst the shortest and thinnest needles that we use in medicine.
Are men reluctant to stick a needle in their penis? I know I would be, for sure.
They often are. I try to explain to them that despite their natural apprehension to sticking a needle in their penis, that because it's such a small, thin needle, that they actually aren't going to experience a lot of pain from the injection itself.
And then when that fails, what's your next option?
Well, generally, if a patient has failed injectables and a vacuum device has been tried or has been proven unsatisfactory, they need to consider moving to a penile prosthesis.
And I notice you have a model of a penile prosthesis. If you could show our audience this model and how it works.
So this is a three-piece. It's called the Titan, actually. Essentially, we say three pieces, and some people say, well, actually, hey, there's four, but the two cylinders are considered one. So essentially, it's two inflatable cylinders in the penis. They're connected to a pump that sits inside the scrotum, and that's all connected in series to this reservoir that holds the fluid. And essentially, fluid is transferred from the reservoir into the cylinders to create an erection. Many men initially are taken aback by all this equipment here, but actually all of this is inside the body, and none of it is exposed or showing. In fact, once a man heals from the procedure, he could be nude in front of another person, and they couldn't even tell that he had the device.
And these come in what sizes?
All various sizes and different girths as well. Essentially, it has to be fit to the individual patient. So while we're in the operating room, we measure the exact dimensions of the man's penis, and we need to place a device that's the right size. If you were to put one in that was too big or too small, it wouldn't work, similar to fitting a shoe on a foot.
Thank you, Dr. Greenfield, for some great information and for being on the show. And thank you, our viewing audience, for watching this edition of the Dr. R Show. Until next time, healthy living and goodbye. You can wait.